Well, welcome everyone. Thank you all for joining us this evening. Hopefully you all are having a wonderful ASCO so far. My name is Rana McKay, and I'll be moderating the meeting this evening. And welcome to Data Plus Perspectives. Clinical investigators discuss the current and future clinical care of patients with prostate cancer. So it's a pleasure to be with you all this evening. So this is our faculty. This evening, I can't think of a more esteemed group to talk to you about the treatment landscape in prostate cancer and where we are with management. Dr. Neeraj Agarwal from the Huntsman Cancer Institute, Dr. Fred Saad from the University of Montreal, Dr. Andrew Armstrong from Duke Cancer Institute, Dr. Himisha Beltran from the Dana-Farber Cancer Institute, and myself from the University of California, San Diego. Here are the relevant disclosures for our faculty. We will skim through these for each of our faculty members, for Dr. Armstrong, Dr. Beltran, Dr. Saad, and myself, and Dr. Love. And this activity is supported by educational grants from Astellas and Pfizer, Bayer Healthcare Pharmaceuticals, and also Johnson & Johnson. The Research to Practice CME Planning Committee members, staff, and reviewers, so they don't have any conflict of interest or items to disclose. And this educational activity contains discussion of non-FDA approved uses of agents and regimens. Please refer to the official prescribing information for each product for the approved indications. We're going to go through several modules going through the evolving management of non-metastatic hormone-sensitive disease with Dr. Saad. We'll go through the MHSPC landscape with Dr. Armstrong. We'll talk about PARP inhibitors and MCRPC with Dr. Agarwal. I'll touch on the radiopharmaceuticals and MCRPC, and we'll end with novel agents and strategies under investigation with Dr. Beltran. So with that, we're going to dive right into the first module, and Dr. Saad will guide the discussion on management for non-metastatic MHSPC.
So thanks very much, Rana, and thanks for the invitation. So this topic, we could have spent a couple of hours, the whole session, but I'm limited to 10 minutes, so just excuse if we go through things quite quickly. But I think this is a really nice evolving space. So when we talk about prostate cancer, I think everyone in this room realizes that it's not one entity, but a whole spectrum of disease from the very early stages of diagnosis and localized disease until MCRPC, which is really the only state of the disease that you die from prostate cancer rather than with prostate cancer, and ideally what we would like is to avoid reaching MCRPC and have people die of other causes rather than prostate cancer. But if we come to the objective of today, it's really looking at patients with high-risk localized disease as a first step, and what we can do to intensify ADT in these high-risk prostate cancer patients. And one of the first studies, or the first study to really show that you can do better than ADT alone in a high-risk or very high-risk population of patients came from the Stampede, published in Lancet recently, looking at patients that had non-metastatic disease, and we all agreed this is on conventional imaging, and they were randomized to 3 years of ADT plus standard of care of radiation therapy, and 3 years of ADT plus abiraterone, or a combination of abiraterone and enzalutamide. And I think the results on their own were unexpected to have such strong results in what is localized disease. Metastases-free survival was significantly improved with a 47% reduction in the risk of metastases-free survival, and then overall survival was reduced by 40% in these patients. So these patients were really high risk, destined to die in a relative short amount of time. So in these patients that are very high risk, we can do better than ADT alone plus radiation therapy. And there are other trials ongoing in this space. Atlas is one of them, looking at very similar high-risk patients going on to radiation therapy, being randomized to apalutamide plus bicalutamide or placebo, and GnRH agonist for 2 years. And Enzarat, again, looking at similar patients, high-risk prostate cancer, going on to randomization, randomized between GnRH, non-steroidal antiandrogen, or enzalutamide and GnRH analog, plus the standard radiation therapy with a primary endpoint of overall survival. I think this is really what changes practice. And we're looking forward to these results that I hope will be coming out quite soon. The sad thing is the results are taking time. The good thing for patients is they're not dying as quickly as we would have expected, which is a good thing given all that we have to offer these patients that you'll hear about. And another study using darolutamide is being studied, the DAZZLE-HiCAP, which includes a mixed bag of recurrent patients and patients that are going on to primary therapy for very high-risk localized disease. And then for the surgery patients, this study has completely recruited Proteus, looking at ADT intensification in patients going on to surgery for high-risk prostate cancer, getting 6 months of ADT and apalutamide versus ADT ADT alone, and 6 months after surgery. And so the endpoints of these studies are going to be reporting, I hope, soon, and they've integrated PSMA imaging as a separate endpoint to try to get a sense of whether we're able to delay metastases. Now, switching gears to a population of patients that is quite worrisome is when we have biochemical recurrence after surgery and or radiation therapy. And when to start ADT in these patients that have biochemical recurrence, clearly these patients are not all similar. And we have this data that's now quite old, but still very helpful, that we can stratify patients into risk categories, looking at when they recur, whether it's in less than 2 years or later than 2 years, and whether they had high-grade Gleason scores or moderate Gleason scores. But the most important factor is PSA doubling time. And you look at the extremes, patients that have long PSA doubling times recur later have only an 8% risk of developing metastases in 5 years versus 73% if they fall in the higher risk category of recurring within 2 years, doubling time less than 10 months with Gleason scores of 8 to 10. So clearly we need to stratify when we would start ADT in these patients. Same thing with PSA doubling time. This is a recurring theme. PSA doubling time is a very strong predictor of early metastases and death. Now, the field has exploded in terms of systemic treatment options for patients with metastatic or advanced prostate cancer. So when we have biochemical recurrence, we talked about ADT, but can we do better than ADT alone in patients truly high risk of early metastases and death? And the answer is yes. So the first study to really address this in a randomized fashion is the EMBARK study that was published in the New England Journal very recently, a year and a half ago, looking at patients with high-risk biochemical recurrence defined as PSA doubling time of less than 9 months after surgery with or without radiation therapy. So these are patients that have high-risk features for early metastases and death, randomized to enzalutamide plus LHRH analog, placebo plus LHRH analog, and there was an exploratory arm of enzalutamide alone. And patients who reached undetectable PSA of less than 0.2 were allowed to stop treatment, and when they recurred, they were put back on treatment. So this was innovative in trying to avoid lifelong ADT in patients with biochemical recurrence. And I think most of you are aware that the results were strongly positive. Metastases-free survival was significantly prolonged, 58% reduction in metastases-free survival in the combination versus leuprolide alone. And all the subgroups were benefiting from the addition of enzalutamide to the standard of care, leuprolide or LHRH analog. Looking at time to PSA progression with the combination over leuprolide alone is quite striking. You basically don't have patients that have PSA progression when they were put on the combination arm. And here, this was a 93% reduction of PSA progression with the combination. Time to first anti-neoplastic therapy, meaning that patients recurred and needed to go on to other therapies because of metastases, was also reduced by 74%. And OS is still immature. You see the the median hasn't been reached, but there's already this trend with, at least with the low number of patients, seeing about a 40% reduction in the risk of death with the combination compared to the standard of care and leuprolide alone. And in terms of safety, there weren't any safety signals that were really worsened with the addition of enzalutamide to baseline leuprolide, and enzalutamide monotherapy looked like it was really well tolerated, as you would expect, with maybe some more fatigue with the enzalutamide alone, and the gynecomastia is something that would have been expected when giving an anti-androgen therapy alone. The question of intermittent versus continuous, this was published already several years ago, that for the non-metastatic patients, intermittent looks like a fine alternative to continuous lifelong ADT. And this was studied in the EMBARK study, looking at patients who stopped, and 90% of patients with the combination were able to suspend treatment because they reached that endpoint of below 0.2. And the duration was almost 2 years of suspension, which I think patients do appreciate. And enzalutamide as an alternative to ADT alone, the monotherapy actually outperformed leuprolide. This was, I think, something that was not expected by everyone, with a 37% reduction in the risk of metastases, and even OS was trending in a direction in favor of enzalutamide monotherapy. Sexual quality of life looked like it favored patients on enzalutamide alone. So this is something that can be discussed with patients when sexual quality of life is important and wants to be maintained. There are other studies looking at this, and this study was recently published with Presto, looking at apalutamide added to LHRH. And here, with a PSA PFS, there was a clear advantage of the addition of apalutamide to standard ADT. And in the subgroup analysis, it didn't matter whether the doubling time was between 3 and 9 months or less than 3 months, the advantage was maintained. There was an arm combining it with apalutamide and abiraterone, and this arm had more adverse events and took longer to have testosterone recovery and had more adverse events. And DAZZLE-HiCap is also studying this patient population of high-risk recurrent. And ARISTEP is the most recent study that's ongoing, looking at these patients with recurrent PSA after local treatment. So to end, very high-risk localized patients with prostate cancer may benefit from ADT intensification and to reduce their risk of becoming metastatic and eventually dying of prostate cancer. Biochemical recurrence is concerning, but not all patients are at the same risk. So we really have to decide who needs treatment. PSA doubling time allows us to evaluate that risk. Lower risk patients could probably be just simply followed without ADT at all, and maybe consider PSMA-directed, metastasis-directed therapy. Higher risk patients with shorter PSA doubling time are clearly in need of better treatment to reduce the risk of becoming metastatic and eventually dying. And patients with optimal response can safely be treated with a treatment holiday, reducing cost and morbidity of treatment. In the end, early optimal hormonally based therapy is effective in patients with potentially lethal prostate cancer. Thank you very much.
Wonderful. Thank you so much for that, Dr. Saad. What an excellent presentation going through the landscape, in the localized setting and the biochemically recurrent setting. We're actually going to dive into some cases. And the first case is going to be presented by Dr. Armstrong, of an individual with NMHSPC.
Thanks, Rana. Fred, this is for you. This is a real-world case from my clinic. A 56-year-old African-American gentleman whose wife prompted him to start getting PSA screening. PSA was 8 at his first test, had a Gleason 8 and 12 out of 12 cores, so you're high-risk localized MHS, non-metastatic hormone-sensitive patient. He had a PET scan, as we now do it for initial staging, that showed no uptake other than his prostate. He underwent a radical robotic prostatectomy, had T3A disease with extracapsular extension and positive margins, and unfortunately had PSA persistence 3 months later. Once he had sexual function and urinary incontinence recovery, he decided to pursue early salvage radiation. His PSA was still quite low, and he elected no ADT because he had just been married a couple years ago, was sexually active, really was trying to avoid ADT. His PSA was low. He had radiation, and despite radiation now, unfortunately, his PSA just keeps rising, and now it's 5. It's doubled over a period of about from basically 0.2 to 5 in 12 months, so rapid doubling time. And now you've gotten a repeat PET CT that shows multifocal, node-only retroperitoneal and pelvic, tiny PET-avid metastatic disease in the lymph nodes. The SUVs range from 6 to 12, no bone metastases, doubling time's about 4 to 5 months. Again, he inquires, he's still very interested in quality of life, minimizing the impact on his quality of life. And so maybe we can have you comment on applying the EMBARK data. What would you offer this guy?
Well, this patient is really more than just high risk. He's actually metastatic based on PSMA. I would, as much as I respect him wanting his sexual health to be preserved, I think this patient is at high risk of metastatic disease and death. So I would really encourage him to take the maximum now with the hope of being able to take a break after an induction of about 9 months of therapy. I wouldn't exclude having a break, even though we see something microscopic, because even in EMBARK, if we had done PSMA in all of the patients, we probably would have found this kind of small deposits of lesions.
So if I could just go back 1 second. So what would you advise him for survivorship? He works full-time, active bicyclist and tennis player. What would you tell him to keep his function as robust as he could as he's getting all this treatment intensification you're recommending?
Well, he seems to be doing a good job. He's a tennis player. He's active. He does bicycle. I don't know how much more I can improve, but I would ask him to at least maintain this, even if he's a little fatigued.
All right.
But this guy is hard to do a lot better.
Well, he ignores your advice, and he picks the enzalutamide monotherapy. He heard that there's better sexual function, as you just mentioned. And so no ADT, and his PSA goes to 0, as you'd expect. After 6 months, he stops therapy, so he doesn't follow the EMBARK 9-month or 7-month regimen. He stops therapy, and pretty quickly the PSA jumps right back up again to 6.4, and now he's reconsulting you if there's anything else he could do to prolong that break, maybe with his next period of hormonal therapy. Is there anything else you would do here?
Well, clearly this patient, I hope now he's convinced. He did his little test. I don't think he worsened the situation much, but clearly this patient needs to have more than enzalutamide alone. I think we need to castrate him with adequate ADT.
What about PET-directed therapy? Would you throw anything in there for MDT?
He seemed to have multiple lymph nodes. That's the problem. If he had a certain region of lymph node, definitely we would be discussing that. And also, and there's a lot of excitement of metastasis-directed therapy, but the biology doesn't lend itself to doing really well. That doubling time, the speed at which it's progressing, the biology doesn't really lend itself, I think.
For his next cycle, would you give him another break, or would you assign him to continuous ADT?
I wouldn't eliminate the possibility of another break if he really responds well. Absolutely.
Yeah. No, that's wonderful. I think some of the most riveting data from the EMBARK study is actually the duration of the hold, that these patients can get a break of up to 2 years with intensified therapy. And I think when you ask a patient, when you're on ADT, just being on to allow you to have a 2-year break is, I think, a huge benefit than getting right back into it less than a year of discontinuing the therapy. So I think this case really speaks to that. We'll go through some additional questions. With the enzalutamide monotherapy, what are your strategies there? Who are the patients that you think are keen for monotherapy? We talked about this individual, and he did the monotherapy and really, failed shortly after discontinuing. But who would you say is an optimal candidate for monotherapy for any of our panelists?
My general recommendation is to avoid monotherapy as a default. So I like, as Fred mentioned, the default being more effective. These are patients with really aggressive disease, and they actually get a longer break. So if you're concerned about sexual function, enjoying that break is how you would recover, and greater efficacy for MFS and possibly OS. So there are patients that are experienced with ADT and may have experienced adverse consequences from leuprolide or a GnRH antagonist, for example. And those would be individual personalized decisions where maybe they had a very bad experience with that injection.
Yeah.
I might
Dr.
just chime
Beltran,
in
yeah.
that this embark population is an evolving disease space with PET scans that were mentioned, and it's really a matter of, treating PET-defined metastatic prostate cancer. And are there any patients that you wouldn't give a doublet therapy and enzalutamide alone, or stopping therapy, and kind of extrapolating between STAMPEDE and EMBARK to figure out, minimizing continuous therapy for patients, which I think is reasonable. But I would say most of these patients, I would get a PET scan and probably would provide even more stronger evidence for doing a doublet therapy over enzalutamide alone.
Yeah.
Great.
But there are some patients, I think, if he had a slower within the high risk, slower, and maybe just one lesion that you could irradiate, I think we could probably get away with monotherapy. But none of us have the answer. Right. This is where shared decision making.
Or no therapy.
Or no therapy, yeah.
That's right.
All right, gang. I love the discussion. We're going to get more of this, but in the interest of time, we're going to go to the next case. This is also a case from my clinic, 68-year-old man who was initially diagnosed in 2021. PSA was 14, abnormal rectal, has an MRI done that shows a focal abnormality with evidence of extracapsular extension, biopsy with Gleason 9 disease, clinical T3A. He initially undergoes a radical prostatectomy, found to have PT3B disease with a positive margin, node negative, and this is another persistently positive PSA postoperatively. Ends up doing external beam radiation therapy, does do hormonal treatment. He completes that in December of 2020. He naders his PSA, but then develops a biochemical recurrence, and you can see the trend there of his PSA 0.3, 0.7, 1.4, 2.8, over a short period of time, PSA doubling time around 4 months. Very similar case, conventional imaging negative, but positive on PSMA PET imaging, and basically labeled as NMHSPC. So he basically ends up starting on treatment with ADT and enzalutamide, a la EMBARK, has a dramatic response. Testosterone is undetectable. PSA gets to be undetectable pretty early on. His toxicity is really mainly fatigue. He's in an exercise program, has some hot flashes, very, very mild kind of like fogginess that he describes, sort of like multitasking, has some issues with that. Current status, 10 months into treatment, as PSA remains undetectable. We're kind of trying to manage the side effects of ADT with a DEXA scan, to look for osteoporosis and calcium, vitamin D supplementation. So I think to our questions now, kind of more generally as we think about what's our strategy for biochemically recurrent disease with a rapidly rising PSA, doubling time with PSMA PET positive disease and conventional imaging negative, maybe, Dr. Agarwal, if you want to share any insights around, what would you do in this context? How do you handle the PSMA PET positive disease?
So this is a patient population which has not been addressed by any of the registration trials in metastatic hormone-sensitive prostate cancer. All the trials, including led by everybody here, have included patients who had metastatic disease on the CT and bone scans. So this is a new patient population, as Misha, you mentioned. And how do we treat them? So of course, enzalutamide plus leuprolide in an EMBARK fashion is one of the treatment options, but this is a patient population where I feel very comfortable giving a limited duration ADT plus ARPI and taking a break if they have very good response. So again, EMBARK-like fashion, like EMBARK-like treatment, but maybe a little longer. So ARA STEP trial is asking that question right now. The ARA STEP trial, for your recollection, is recruiting patients who have PSMA PET positive disease, conventional scan negative disease, and these patients are treated with ADT plus darolutamide for 2 years, and then they take a break. So this is how would I approach the patient.
Wonderful. I think that you're hearing consensus from this panel for these high-risk patients that are conventional imaging negative, PSMA PET positive, having some comfort with treating with intermittent therapy. And if we look at the EMBARK data, actually a single institution analysis of an EMBARK-like population actually demonstrated that about 80-some-odd% of patients, 86% of patients that met the criteria to enroll in EMBARK actually had positive PSMA PET scans. So I think if we had gone back and actually in hindsight done PETs on these individuals, the median PSA for these patients was 5. We would have found occult disease on those imaging. All righty. And outside of a clinical trial, would you currently employ a AR pathway inhibitor outside of enzalutamide in this context for those patients that have biochemically recurrent disease? Dr. Agarwal.
Yes. Technically, we can get any ARPI for these patients nowadays. We call them MHSPC based on PSMA PET scan. I just want to remind myself that these are the patients who have lowest volume MHSPC, and they deserve to get breaks if possible.
Dr. Armstrong, did you have something to add?
I agree. I mean, not everybody is fit and suitable for enzalutamide. I mean, particularly older and more frail patients, perhaps those on many medications where enzalutamide can induce their metabolism. Perhaps they're at fall risk. Darolutamide is a very good choice. That's why it's being studied in ARISTEP. There are alternatives that are proven to extend life, as I'll talk about in a minute. But I think, right now enzalutamide has level 1 evidence, so that would be your default. But there are patients where you have to personalize that decision.
That's fantastic. Well, what a perfect segue into the next discussion, which is the treatment of metastatic hormone-sensitive prostate cancer.
Thanks, Raina. And thank you, Dr. Love, for listening in. All right. So we're talking about metastatic hormone-sensitive prostate cancer using conventional imaging, and it's been an outstanding decade of progress in the field, starting with the charted data that blew away ASCO 10 years ago now, with the surprise finding by Chris Sweeney that docetaxel, and particularly high-volume patients, extended survival by 17, 18 months in 2014. And there's been an incremental data presentations over the past decade from the Stampede, the Latitude study, Arches, Peace One, Enzamet, Titan, ARANOTE, and ARASENS, all suggesting that treatment intensification should now be the standard of care for all patients that have metastatic disease. Now, at this ASCO, stay tuned for Tuesday. There will be updates. We'll be presenting the 5-year updates on Arches. I think the Enzamet data has 84 months of follow-up. The very first hormone-sensitive PARP trial will be presented on Tuesday, so stay tuned. These are currently the level 1 evidence-based trials that have been published to date that suggest improvements in survival. And you don't need to read all these, but basically all of these data suggest that treatment intensification improves survival very similarly. If you look at the hazard ratios for enzalutamide, abiraterone, apalutamide, darolutamide, the hazard ratio is around 0.6 to 0.7, so around 0.66 on average, very similarly but across the class of ARPIs. Radiation to the primary, we can't forget that. The hazard ratio for improving survival in low-risk patients is 0.68, so it's as good as our best systemic therapies. Triplet therapy, right at the bottom there from the Peace One and the ARASENS trial, suggests that in high-volume patients, which I'll show you next, we have improvements in survival. So if you want to think about an algorithm, some of the branch points that we use to treat patients have to do with high-volume disease versus low-volume disease, again, based on conventional imaging using the charted criteria. So if you have polymetastatic disease or visceral disease, that's high volume. If you have oligometastatic disease, that's low volume by conventional imaging. We have these branch points based on synchronicity or relapse disease or metachronous disease, where basically doublets for everybody, but triplets particularly for the high-volume patients. And the high-volume data comes from 2 really level 1 evidence-based trials where ADT docetaxel was the backbone. That became the standard of care again in 2014, so that built on that standard of care, where darolutamide extended life even beyond ADT docetaxel with a hazard ratio of 0.69, but predominantly in those high-volume patients. And likewise, in the Peace One study, you see on the right-hand side, in the high-burden patients, ADT docetaxel, you see a added survival benefit with abiraterone. Now, we don't have the opposite data where ADT ARPI plus minus docetaxel has been studied. That's going to be a cooperative group study. That's a really important question to ask, is what is the relevance of docetaxel now in an ARPI world, AR pathway inhibitor? ARANOTE, thanks to Fred and his colleagues, was conducted and presented and published just in the past year. ARANOTE was the global test of darolutamide as a effective agent over ADT alone. Radiographic progression-free survival was an appropriate endpoint at that time because we already had many ARPIs on the market, and this was a test to really see if darolutamide could extend the duration of progression-free and then subsequently perhaps overall survival. This trial was a very positive study. The hazard ratio is 0.54 for RPFS. The overall survival data is still immature, and that's largely because this study was unblinded and was positive for its primary endpoint. We have immature follow-up at this point. But this was a positive study, not just for efficacy, it met all of its key secondary endpoints around PSA, for example, but also for its safety, with a very clean sheet of safety data. If you look at who are benefiting from darolutamide, you can't really find a subgroup of patients, perhaps other than those with visceral, particularly liver metastases, that are not doing as well with an ARPI, and that's true of all the AR pathway inhibitors. We don't have really, we have not met this unmet need of addressing patients with liver metastases other than with docetaxel as part of triplet therapy. But all subgroups, regardless of where you live in the world, your age, your Gleason score, your disease volume, are benefiting from treatment intensification. We'll be presenting data on Tuesday. I can't show that yet, but this is the data from the ARCHES study where we're updating this, going out to 60-plus months at minimum follow-up. What we'll be showing is there's a 13% absolute benefit in overall survival. What I found particularly impressive about the follow-up data was that the high-volume patients had an extra extension of life by 3 years. So that's an improvement by 3 years. So that was a big benefit to early intensification therapy. Now, there's some other data you may not have seen. This was just published in the past few weeks. There were some questions that I commonly get in the community about, well, I've started ADT and the PSA is already down. Do I need to intensify therapy? And we tried to answer this with the ARCHES study because in ARCHES, you enrolled after up to 3 months of ADT, and some patients had already reached a 0 PSA. As you can see in the top graph, there was still a survival benefit for those patients who had already reached an undetectable PSA. There was a survival benefit if your PSA was between 0.2 and 4, and then there was a clear survival benefit for those patients who had a suboptimal ADT response. So all groups of patients, regardless of the baseline PSA, had a survival benefit, and that just speaks to the ability of treatment intensification to control disease in a more durable fashion than ADT alone. The second question was the PSA nadir. What is the prognostic significance of reaching a very low PSA? And as you can see here, you can communicate updated prognoses to your patients at this about 6-month landmark. Patients tend to reach their lowest point. Sometimes it's a little longer, but a patient who achieves a PSA that's less than 0.2, you can see that 80% of these patients are still alive going out about 5 years. In the TITAN study, similarly, apalutamide extended survival and radiographic progression-free survival very similarly. And there's some really interesting data on the PSA declines from the TITAN study as well. Now, this assay that they measured in TITAN went down to 0.02, so they called this ultra-low PSA. And you can see here that getting your PSA down even farther with apalutamide was associated with an even better extension of survival. So the lower, the better. It's kind of like limbo. You'll see on Tuesday data from the global Ironman registry that this same data is validated in a real-world setting across the world outside of a clinical trial, so that's reassuring. You can also see from the very bottom graphs that sometimes it does take a little while to reach that ultra-low PSA. It's definitely not always just at 3 months, not always just at 6 months. Sometimes even happens more slowly between 6 and 12 months. As I'm trying to make decisions between AbbVie, Enza, APA, and Dara, we have a lot of choices. Abiraterone is now generic. It's certainly considered one of the more cost-effective regimens, but it does require prednisone. It requires a little more intensive hepatotoxicity monitoring, electrolyte monitoring. It can cause mineralocorticoid excess, requires 5 milligrams of prednisone to offset that. There's home blood pressure required, monitoring required, but it all of these drugs are very safe when combined with radiation, whether that's prostate radiation or metastasis-directed radiation. For Enza, APA, and DARA, there's no prednisone requirement. There's really no liver injury, no electrolyte monitoring, no mineralocorticoid excess, but there is blood pressure monitoring required. So I have home blood pressure monitoring recommendations for all patients, exercise recommendations for all patients, monitoring of bone density regardless of which ARPI you pick, because you do see osteopenia, osteoporosis, and a higher fracture risk. And so it's really personalized. A lot of this is based on age, comorbidity, toxicity, availability, and patient preference. Just to finish up, we have done some cross-trial comparisons. I know you're not supposed to do cross-trial comparisons, but we all do. And so we did what's called a matching adjusted indirect comparison. This was presented at EAU 2025. So we took the ARCHES data and compared it to ARANOTE. And we do find that there's a suggestion of improved efficacy with enzalutamide as compared to darolutamide. We're not able to compare survival data here as the data is still immature for one of the studies. But there's some suggestions that some of the ARPIs may have differences in efficacy. Now, others have looked at this in the STOPCAP meta-analysis. This is the UK Oxford group. They have access to many of the ARPI data sets as well as the Latitude and Stampede data sets. They do demonstrate and confirm that treatment intensification is associated with improved PFS and overall survival. But importantly, they've been able to look at older patients. You know, it's very common for us to see patients 75 and up, and they see in the ARPI trials that these older patients are doing a little bit better with an ARPI. In the middle, you see abiraterone. The older patients not doing as well with treatment intensification with abiraterone. Possibly this is due to toxicity, cardiovascular risk, some concerns over long-term toxicity, particularly in the older patients. So as I'm trying to make a personalized decision, you're weighing, your patient that's in front of you, the efficacy, the level 1 evidence that you have, but it's very personalized to that patient's comorbidities, their preferences, the safety data, and obviously the financial toxicity. So we're going to see a lot of changes in the next couple years. Just in the next 1 year, perhaps we're going to see data from the Capitello study for PTEN loss. We're going to have Amplitude, TALAPRO-3, EVAPAR-02. These are PARP inhibitor trials. We've completed enrollment on the PSMA lutetium, PSMA addition trial. Just a great time to be an oncologist, I think, in prostate cancer. We didn't used to have this 10, 20 years ago. We're now testing metastasis-directed therapy in the Stampede 2.0 arm. We're going to be generating tons of level 1 evidence that should hopefully change practice. And I'll stop there. Thank you.
Wonderful. Thank you so much for that, Dr. Armstrong. You all got to stick around for Tuesday. Tuesday's going to be a big day. There's so many presentations happening. It's a big oral prostate session is Tuesday morning, so stick around. So next we're going to do some case presentations. Dr. Agarwal, take us with the first case.
So this is a case of metastatic hormone-sensitive prostate cancer, which was treated by us with apalutamide. So you can see this 67-year-old man, otherwise very healthy, presents with synchronous high-volume metastatic prostate cancer in 2021 June, and with a Gleason score of 4+4. Next. Oh, I can move it. So this is the bone scan showing high-volume disease. And he was started on, so at the time of diagnosis, he had high-volume metastatic disease, and his PSA is 28. And if you look at the genomic profiling, we didn't see any PARP inhibitor targets. We didn't see any HRR mutations. Otherwise, we could have enrolled him on a clinical trial. So he has SPOP mutation, which is associated with good prognosis. And another mutation, I really don't know the significance in the clinic right now. And we started him on ADT plus apalutamide, and patient continues treatment for a long time. And here, patient is almost 4 years out and continues to receive the same treatment. But I'd like to highlight the PSA response. Patient achieved 6 months after starting ADT plus apalutamide, and it was 0.1. And it has continued to be very low, undetectable PSA. So I have contemplated taking a break. Patient has asked me recently, Can I take a break? It has been 4 years. I don't know if the data supports that. So I'll ask a question to Dr. Beltran. This is a patient really doing really well, undetectable PSA. 4 years after starting ADT plus apalutamide, SPOP mutation, would you take a break? If patient is asking for it without major side effects.
Yeah, I mean, of course, this is an area that we'd love to have more data, and there is de-intensification trials being planned in this space. But I think in the absence of that, I think given what our conversation before about even if we think of this as one stage past the non-metastatic HSPC population where we are doing intermittent therapy, and we know that all the ample data of showing how prognostic getting a PSA undetectable is and weighing the side effect profiles of being on continuous therapy, I think it is reasonable to have that discussion. And SPOT mutations are, of course, associated with increased sensitivity to AR pathway inhibitors. And I think it would be a shared decision-making at that point with the patient.
Dr. Saad, what do you think a patient has severe side effects? Well, then it becomes easy. I'll make it a little difficult for you.
Well, even if he has severe side effects, I'd really like to relook the imaging.
Yeah.
Right? I mean, we do have patients that have undetectable PSA that don't have complete response on imaging. I need to have as much reassurance as possible that what we're going to do is safe, because he started as high volume disease. A low volume patient, I'm a little more comfortable, but a high volume, I'd really want to be sure. And we're publishing some data that some patients do develop metastases with very low PSA. So this is probably just a message that PSA is very reliable, but there are some patients that play tricks on us over time. But if everything is fine, I agree with Misha. I mean, it's a shared decision. Patient wants to take a break, take a break.
Well, overall, great outcome. Andy, any other comment on this?
Yeah, just to echo Fred's comment there, we have data across several phase 3 trials of our piece that PSA progression should not be defined the same way. In fact, 10 or 20% of men are progressing radiographically with a 0 PSA in this setting. So I would get imaging, including soft tissue imaging, but if there is going to be a patient who benefits from intermittent ADT ARPI, like the ADREAM study that's being done, it would be this patient because of the SPOP mutation. So I think it's a great shared decision-making discussion.
I love that ADREAM study. It's not yet published, but I think it's asking those questions that we have in the clinic. It's a study run through the cooperative groups where patients achieve an undetectable PSA after 2 years of ADT abiraterone for MHSPC, and then actually does institute a break for those individuals with data to resume therapy, actually when the PSA gets up to 5. So I think we need to conduct those studies to really help us define what to do in this context. There is no level 1 evidence right now to actually guide what to do in that context. All right, continuing to kind of move along, I think we touched a little bit on the data that's came out at GU ASCO from StopCap around abiraterone with older adults. What are your interpretations of that data, Dr. Saad? Any input on use of abiraterone in an older individual and enthusiasm for that?
I'm going to share my bias. Even in a younger patient, I don't like abiraterone. I prefer not to use prednisone for several years in these patients that are going to do well. I prefer, when we have an option, to not have to be doing electrolyte checkups. And you lower to 5 milligrams of prednisone, and all of a sudden you get 12% grade 3 hypokalemia, 22% grade 3 hypertension. So it's not just the prednisone, it's the abiraterone. So with alternatives, I prefer not using abiraterone, regardless of age.
Yeah. Dr. Armstrong, do you have it, how do you weigh the risks and benefits of which agent to select? I know you touched on that in your presentation. There's a lot to consider. Do you find that you are selecting different agents for different people coming into the clinic?
Yeah, age is just a number. So I try to do some sort of fitness assessment. So if they're younger but still infirm and very sedentary, I treat them like an older patient. Or if they're very much 75 and up but still really fit and active, then I might treat them like a younger patient. But I agree with Fred. Abiraterone certainly has, in many studies, including VA studies and other large retrospective chart reviews, we see enhanced cardiovascular risk with that. And it's kind of a perfect cocktail of hypertension, hypokalemia, atrial fibrillation, older patients, steroid use. That can create cardiovascular risk. So, really getting patients into a physical therapy program, an exercise program, making sure that they're having their cardiovascular risk minimized, perhaps with a cardio-oncologist by lipid monitoring and other tools to reduce that risk regardless of the treatment strategy.
That's awesome. And I know we touched a little bit on the taking a break in this context. So we'll go to our next case with Dr. Beltran.
Thank you, Dr. McKay. So this is a 55-year-old gentleman who presented to his PCP with his first screening PSA, which was 664. So he feels well overall. He reports urinary frequency, no back pain, fatigue. He has some fatigue, but no weight changes. He had a prostate biopsy that showed Gleason 4+4 prostate adenocarcinoma and a PSMA PET scan that showed multiple metastases, pelvic, retroperitoneal lymph nodes, high-volume bone mets, sub-centimeter lung node lesions. He was started on ADT locally by his urologist with Zegarelix and comes in to see you just said to us to see is he a candidate for additional therapy. His PSA is now down to 98 with a castrate level of testosterone. He's otherwise healthy, has a history of hypertension, controlled on amlodipine and hydrochlorothiazide. So this was a case really to illustrate young patient, high volume, de novo, metastatic prostate cancer, thinking about the role of triplet therapy. Something I would discuss, even though Dr. Armstrong already presented the data on what kind of patient you might consider, and the fact that it wasn't compared to doublet, but this is someone you might want to be very aggressive with. And in this case, with the hypertension, he's on 2 medications for that, maybe would lean towards a darolutamide, docetaxel versus abiraterone, given comorbidities. And we already discussed that. I think maybe what I would like to ask, maybe Dr. Armstrong, is what, in a patient like this, would you consider 2 things? One, would you consider radiotherapy to the prostate in a patient like this, and when would you do it? And is there a role for repeat PET imaging in a patient that presents with de novo high volume?
Those are all great questions. I mean, in a high volume patient, we have no data that radiation to the primary extends life, but we have data that it may prevent urinary obstruction, and that may impair quality of life. And so I think I would look at how their urinary symptoms are, the bulk of their primary. If they have T4 disease, I would consider it as a way of palliatively preventing that catastrophe down the road. But I don't have any level 1 data that would extend their life. Now,
and practically, when would you do that? Would you do it when his PSA is at nadir? When you do it?
In this guy, I'm going to recommend triplet therapy. So I would not do it until I'm completed with the docetaxel and I've reassessed the patient. And if they're doing great and their prostate's small and they're not having any symptoms, I'd probably defer that decision. But this patient deserves a trial of docetaxel. I mean, sometimes patients come to me and they're so happy that their PSA is down from 664 down to 15, but that's not actually that great. As we showed, if the PSA is not below 0.2, that patient has quite a miserable prognosis. That patient's going to experience castration-resistant disease probably within a year or two. So 98 sounds better, but it needs to go down further, and the lower you go, the better.
Great, wonderful. I think we segued a little bit into, how do you select triplet therapy? We talked about selecting between the different doublet RPs, but how do you decide? How do you pick whether to go down the road of triplet or doublet when we don't have level 1 evidence? Maybe Dr. Agarwal, you can touch on that a little bit.
Yeah, so there is no level 1 evidence, as we discussed already, comparing ADT plus RP versus ADT plus RP plus docetaxel chemotherapy. So I do use chemotherapy for a very small number of patients who seem to have very aggressive disease. I think ADT plus RP combination is good for high volume, low volume, de novo, and non-de novo disease for most of the patients, especially with genomic profiling being available in the clinic easily. Unless I really see, and this is again, because we don't have level 1 evidence, I cannot really say ADT plus, like triplet is better than ADT plus RP. So I really look for visceral metastasis, tumor suppressor gene mutations, and if I see them, I'm more likely to offer them triplet therapy.
And you've done some excellent work looking at lung metastases in people with advanced prostate cancer and kind of dissecting out the differences in outcomes based off of lung and liver. Do you want to speak to that a little bit?
I personally think all of us have same experience, that lung metastases are the most indolent type of metastasis. These patients have natural history, which is very close to what we see with, I would argue, patients with lymph node metastasis. maybe bone metastasis. I really worry if I see patients with liver metastasis at the outset.
Yeah. Yeah. All right. Great. Well, we're kind of moving along. Okay. Next module is going to focus on PARP inhibition and metastatic CRPC. Dr. Agarwal, take us away.
So a lot of data have come up in the last 1 or 2 years. So I'll go through those data really quickly, but just to emphasize the value of looking for germline, doing the germline testing, about 11 to 12% of patients with metastatic prostate cancer have germline pathogenic variants, which can affect their family members, their children, their siblings, which can develop fatal disease. So this is extremely important that we look for those. And indications and practical implementation of genetic testing has been endorsed by multiple guidelines. And we don't have to repeat all of this, but pretty much every major guideline endorses or recommends germline testing and tumor somatic testing to look for these mutations, especially HRR mutations, for multiple reasons. So coming to the more recent topic, what is the rationale for combining PARP plus RP, PARP inhibitor plus ARPI? The data has been present since 2012, started published from Dr. Karen Knudsen's lab. More recently, ASCR meeting 2 weeks ago, it was shown that one of the major co-activators of AR is involved in DNA repair. So just to summarize all of that, the way I explain to my patients that when we target cells with ARPIs, that leads to PARP upregulation. PARP comes to the rescue of these cells. And when we target both AR and PARP, that leads to a more synergistic killing of the prostate cancer cells. To just keep it simple. But we have published this paper. This is an open access paper, which has all the evidence so far in this context. So coming to the phase 3 trials first, all these trials look very similar. These trials have newly diagnosed metastatic castrate-resistant prostate cancer patients who were randomized to RP plus PARP versus RP alone, or RP plus placebo. So we can see the PROPEL trial presented by Dr. Armstrong and team, Magnitude trial, and the TALA-PRO2 trial. So just to walk you through these individual trials quickly, PROPEL trial was again, big trial, about 800 patients. Patients with newly diagnosed mCRPC were randomized to olaparib plus abiraterone versus placebo plus abiraterone. Radiographic progression-free survival was the primary endpoint. There was an 8 months improvement in radiographic progression-free survival. And these patients are all-comer patient population. They were not necessarily recruited because they had HRR mutations. And if you look at the overall survival, the pre-specified criteria were not met. So overall survival was not positive, but we can see that there was a trend favoring the combination. If you dissect the data further and you look at those patients, those 30% of patients who had HRR mutations, obviously overall survival data are stronger than patients who did not have HRR mutations. So this was the PROPEL trial, which met the primary endpoint and led to approval of abiraterone plus olaparib for patients with newly diagnosed mCRPC with BRCA1 and BRCA2 mutations. Now let's look at the Magnitude trial. So Magnitude trial is another similar trial, but in this case, investigators decided to test these patients upfront, and patients who had HRR positivity or HRR gene mutations, they were randomized separately from patients who did not have HRR mutations. And in patients who did not have HRR mutations, the trial was closed early for futility without looking for radiographic progression-free survival. Patients who had HRR mutations, the benefit was mostly present in patients with BRCA1 and BRCA2 mutations. So if you look at radiographic progression-free survival in these patients, by both central review and investigators, there was clear improvement in radiographic progression-free survival. And if you look at the if you look at the overall survival data, it was not positive, but if you look at pre-specified overall survival analysis, which looked for difference in baseline factors, there was a significance for overall survival with abiraterone and niraparib in patients who had BRCA1 and BRCA2 mutations. So this is the final analysis which I was talking about. So this combination, abiraterone plus niraparib, is approved in the US for patients who have newly diagnosed mCRPC and they have BRCA1 and BRCA2 mutations. So now let's look at the TALA-Pro2 trial. It was something, these trials are very similar, but they have inherent differences. So in this trial, if you look at the design on the left side, lower down, you can see that it was a large trial, again, about 1,000 patients. And the trial first recruited about 800 patients who were all-comer patients. They had testing, but testing results did not decide whether they are going to be randomized to one or another arm. So all-comer patient population. And once they were recruited, another 230 patients were recruited who were HRR mutations. So I will show you the data in all-comer patients and patients who had HRR mutations. So let's look at the radiographic progression-free survival. And if you just look at the updated analysis on the right side, there was a 14-month improvement in radiographic progression-free survival. I'd like to bring your attention to the fact that 33 months used to be the overall survival in these patients, based on all the early trials done 10 years ago, leading to approval of enzalutamide and abiraterone. So it was striking to see the delayed radiographic progression-free survival in this all-comer patient population. And overall survival in all-comer patient population was also met with a 20% reduction in risk of death and about 9 months improvement in overall survival. Now, if you look at the patient population which had no alteration, this is post-hoc analysis, so I'd like to bring to your attention that it was not pre-specified. In these patients who did not have HRR mutations, even in those patients, although it's a subset analysis post-hoc, I would just say that the combination was favored as far as overall survival was concerned in patients who did not have any HRR mutations by both ctDNA and tumor tissue testing. So combination seems to have activity regardless of HRR mutations, but in patients who have HRR mutations, the overall survival was improved by 14 months. So quite striking overall survival benefit from 31 months to 45 months in patients who had HRR mutations. In the US, the combination is approved only for those patients who have mCRPC and they have HRR gene mutations. So this is the overall survival benefit I was talking about, 31 months to 45 months. So very striking data. And based on that, these combinations are approved now for mCRPC patients with BRCA1 and BRCA2 mutations, for abiraterone-based combinations, and for enzyme TALA, the combination is approved for any HRR mutations. So this is a summary of the data. I'm not going to go through that, but we do have overall survival benefit in the TALA-Pro2 trial, which was not seen by other trials. But beyond that, I think the label is for BRCA1 and BRCA2, again, for abiraterone-based combination, and for talazoparib for all-comer patient population. So I'd like to discuss the BRCA data briefly. This is an investigator-initiated clinical trial, which we started about 7 years ago, before all these phase 3 trials were started. And the question was whether sequencing is better or early on we should combine these drugs. So very simple question. Is upfront combination is a better strategy than the sequencing? This is a small IIT study. 20 patients in each arm. So I will not take too much out of it. But if you look at the progression-free survival, it was 39 months in the abiraterone plus olaparib group, and it was much less in olaparib single arm or in the abiraterone single arm. And then these patients were allowed to cross over. So if patients were randomized to abiraterone first, they were allowed to cross over to olaparib. And olaparib patients were allowed to cross over to abiraterone. And if you combine the PFS from abiraterone followed by olaparib or olaparib followed by abiraterone, we see a combined PFS of 16 months. If we look at the abiraterone plus olaparib PFS, that's 39 months, very similar to what was seen in the PROPEL trial. So these data kind of convince me that upfront combination is better than the sequencing. And that is my practice. So if I have a patient who is eligible, I tend to favor combination strategies. These are the 3 trials which are ongoing. Amplitude trial data will be presented on Tuesday. Hopefully, we'll see positive results. And then TALAPRO 3 trial is hopefully will be presented soon. This is, again, testing the same combination of Enza plus Tala in hormone-sensitive setting in patients who have HRR mutations. And then EvoPAR Prostate 1, it is testing a new PARP inhibitor, a selective PARP inhibitor, and these data hopefully will be available in the near future. The only difference is in this trial, both HRR mutation positive and negative patients are being enrolled, but they are being randomized separately. With that, my take on PARP plus ARP and mCRPC, combination is better. Sequencing is likely not preferred by me, my personal bias based on BRCA data. And all patients need sequencing. A lot of patients are not being sequenced, so let's get out sequencing testing out for our patients. Thank you very much.
Thank you so much for that. It's a lot of data to kind of delve into and make sense of. We're going to go into some presentations first with Dr. Beltran.
Thank you. So this is a 69-year-old gentleman who was diagnosed with T3A N0M0 Gleason 4+5 prostate adenocarcinoma 4 years ago. He was treated with radiotherapy, 2 years of ADT, had a nadir of PSA 0.3, came off after 2 years, was then lost to follow-up and has not had regular PSA checks, and now comes in with a PSA of 10, with the testosterone still being low, and he has multiple bone mets on scans. He feels well, he's asymptomatic, and he has a family history of breast cancer, and he had genetic testing that had a pathogenic germline BRCA2 mutation. So Dr. Agarwal, would this be a patient that you would consider for combination ARPI plus PARP inhibitor? And what if the patient had had a prior ARPI? What would be your rationale?
Great question. This is a case scenario we often see in our clinic. Most of the patients in U.S. present with localized prostate cancer, they receive ADT for short durations. And then when they develop mCRPC, many have low testosterone like you are presenting here. So in this patient, answering your question, there are 3 combinations which are applicable to this patient. Abiraterone plus olaparib, abiraterone plus niraparib, and enzalutamide plus talazoparib. Further decision will depend upon copay, other drugs patient is on. Many patients cannot be on enzalutamide because they are on certain blood thinners, and many patients cannot be on abiraterone because they have certain cardiovascular issues. So those will ultimately define the treatment selection. Now, if they have received ARPI, but they have not progressed on ARPI, I will probably go with the combination again. If they have progressed on ARPI, then that question was not answered by any of those phase 3 trials.
Yeah, thank you so much for that summary. I know the data can get pretty complicated with the AR combination therapy, so just kind of to level set, the FDA approval for olaparib, niraparib is in BRCA1/2 mutated. For olaparib and abiraterone, it's for also BRCA1/2 mutated. For talazoparib, enzalutamide, it's for a panel of HRR genes. That's where the FDA label lies. All of these trials largely did not enroll patients who had gotten escalated in the MHSPC setting. So like Dr. Agarwal said, this is an unmet area where we don't really have good data. There was about 50 patients in the TALAPRO 2 trial that had received an ARPI in the MHSPC setting, but it's really hard to glean exactly what to do in that context. There's actually currently a phase 2 study being designed through the PCCTC with the PI of Dr. Alicia Morgan's actually looking at answering that question for patients that did get escalated in the MHSPC setting. What is routine practice now, us getting, giving patients an ARPI, actually randomizing patients to switch to enzalutamide or do talazoparib versus talazoparib plus enzalutamide. So I think hopefully we'll have some data, but this can get pretty murky. And for all of our European colleagues in the room, the label is different in Europe than it is in the US, and the label for olaparib plus abiraterone is for all comers by the EMA, and for niraparib, abiraterone, it's for BRCA1/2, and for talazoparib, Enza, it's all comers. So I think the data can get a little bit messy, and so we try to hopefully clarify that for you all.
But if it's a BRCA mutated patient who's progressing on ARPI, there is monotherapy, which would be the approved standard of care. So I think what we're talking about here is we'd like to do better than monotherapy.
Yeah, absolutely. Well, how do you pick choice of agent when you are picking combinations and you've got a BRCA mutated? How do you pick between, olaparib, abiraterone, niraparib, abiraterone? Maybe Dr. Armstrong, you can try to tackle that for me.
It's a tough decision. You can't really do cross-trial comparisons, although we do. The Propel data if you look at the hazard ratio for overall survival, it was in the 0.2 range. It was a phenomenal separation of the curves. Very, robust survival benefit with talazoparib as well. Not as robust with magnitude, just not as much magnitude. But I think, between those two choices, I think both are winners. Both are considered level 1 evidence and NCCN guidelines. Both would be considered, it's really about the AR pathway inhibitor. I think if you're going to pick the AR pathway inhibitor first and then match that with the PARP inhibitor of your choice, and that's going to be, as Neeraj mentioned, based on drug interactions, cost, copays, perceived toxicities, age, comorbidities, like we talked about earlier. It's important not to mix and match ARPs and PARPs. So if you're using abiraterone, don't use talazoparib, and if you're using enzalutamide, don't use olaparib because of drug-drug interactions. So I think that's the main message.
Well, thank you for clarifying that. We're kind of going to go into our next case with Dr. Saad. Do you want to go through your case here?
Yeah. So this is a patient who was 61 years old when he was diagnosed with prostate cancer, clinical T3, Gleason 8, PSA was quite high, 42. He went on to radiation therapy and 3 years of ADT, which would be considered the standard of care at the time. PSA was undetectable in 2017. And then, unfortunately, in 2019, he had a PSA rise to 4.5 with a doubling time of 6 months. Negative workup. At the time, we didn't have EMBARK data to help us treat this patient, so he was put on ADT alone. Did well for several years, and then became castration resistant, and at re-imaging, he was now metastatic castration resistant. He had a lymph node biopsy because we don't really test on tissue that's 10 years old. It's really not really useful to go back and get a biopsy that's 10 years old and try to do genomic testing. So when we have the opportunity, we re-biopsy for fresh tissue, and it revealed a BRCA2 mutation in May 2023. So.
Yep, and I think...
So before I go to what we actually did you want to ask any question? But, this is a patient with a BRCA mutation who's newly diagnosed. I think it goes back to the case that we just discussed.
Very similar.
But I think this is, it would be almost unethical not to treat this patient with all the data we have. We're not talking about non-mutated patient here. We're talking about BRCA2 mutation, delaying treatment in this patient. You're going to shorten their life. It's as simple as that. The data is just too strong to not treat this patient that you've diagnosed with a BRCA mutation. Patient's well informed. He accepts abiraterone and niraparib. PSA rapidly declined from 8.1 after 1 month of treatment down to 2.3. At 8 weeks, he had symptomatic anemia. And this is something that we have to deal with PARP inhibitors, especially in the early few weeks of therapy. It does happen. You have to be attentive. We actually test patients at the beginning at 1 or 2 weeks after starting therapy. Sometimes it's quite early. He was transfused 1 unit, and 1 week later was put back on niraparib at a reduced dose of 100 milligrams and is doing very well and continues to have undetectable PSA with complete response of all measurable disease. So this is, I guess, what we hope to get when we treat these patients.
Absolutely. I mean, I think this is a perfect example. These patients who have BRCA alterations that are not escalated in the MHSPC setting, this is the group of patients that derives the greatest benefit from combination therapy. They really can't catch up, and I think the data would suggest that early use of olaparib for patients who are BRCA mutated is really key. We see that actually from even the Triton data that did the comparison looking at monotherapy rucaparib compared to docetaxel. So I think early use is really key. So kind of delving into some of this data, what do you where do you think the field is going to go with regards to PARP inhibitors for MHSPC? I feel like I'm having you look into the crystal ball for what Tuesday holds for us, but maybe Dr. Armstrong, if you want to share some insights on how you think the integration of PARP inhibitors for MHSPC will work.
Well, as Neeraj mentioned, the ARPIs the PARPs are following the ARPIs. So the ARPIs are now in the hormone-sensitive setting. So in my practice, I don't know about you, but I don't see very many Propel or Talipro-2 type patients anymore. I think that is the patients who are only getting ADT alone, you still see them maybe 10 or 20% of the time. In the community and rural practices and solo urology practices, it's much more common, and globally it's very common. So I think, there's still those types of patients out there, but you get a much greater efficacy with the AR inhibitors early on in the hormone-sensitive setting. So that's where I think you can take advantage of that, and hopefully we'll see that at least with niraparib on Tuesday. But the question is, will it improve survival? There are some concerns that the earlier use may cause more DNA damage to bone marrow, that it may preclude the use of later drugs like PSMA lutetium or chemotherapy. We'll just have to see how subsequent therapy is handled by those patients.
And maybe for Dr. Beltran, if you want to think about, we're just starting to discuss, earlier use in the MHSPC setting is going to be more prolonged use for longer periods of time. Sometimes people stay hormone sensitive for 3-4 years at a time. And these studies are integrating use until time of progression. So thoughts?
Yeah, it's a really important point. These are not easy drugs to give, and they cause anemia, there's transfusions, people have fatigue, and as you go earlier and you have them for longer, you worry about that. But I just highlight that these BRCA patients have very aggressive disease, and sometimes I really believe that earlier is going to be better. We'll see what the data shows, but you have to imagine that if you have an available therapy, you should, and the data supports it, that most likely these patients are going to require intensified treatment. And I think that's what these combination therapy trials are also showing us, is that you don't necessarily want to wait because they can declare themselves and do very poorly with the BRCA mutation.
Thank you.
I just like to make a point.
Absolutely.
So there is I know we have discussed the BRCA2 mutations only, but there is an oral presentation also on Tuesday, so please join us in that session where data from other HRR mutation gene-by-gene analysis will be presented from the TALAPRO-2 trial, which is hopefully will give more insight to us on how we can apply the combinations to other gene types.
Thank you. Thank you for that. A lot of data to dissect there. Before we break from PARP inhibitors, I think the key message is to test. You have to test. You have to test the tumor, you have to test the germline for these individuals. It's predictive, it's prognostic, and certainly for the germline piece, it can inform cascade testing and also secondary screening for that individual, given the indication for germline testing is even in the high-risk localized setting, and that patient can have a long runway for getting a secondary malignancy. So test, test, test. Okay? All right. So we're going to transition on to radiopharmaceuticals and MCRPC. We're really just seeing an explosion of these agents, where we are currently, where we are in the future. So I thought I would step back and actually just sort of highlight a little bit just about the pharmacology of these radiopharmaceuticals. You obviously have the target, which is the tumor, and on the tumor, you've got a receptor then there's various different receptors that could potentially be targeted. And then you've got your targeting agent. How do you block that protein that's on the cell surface? Do you block it with a peptide? Do you block it with an antibody? How do you actually target it? And then you've got, the molecule, the therapeutic, which is this target that's linked via a linker to a radionuclide, which could release an energy source with different degrees of energy, whether it be a beta emitter or an alpha emitter. And then you've got the tumor that sits around the healthy tissue, the tumor that sits around other tumors when we think about bystander effect and so forth. So, I think this is important to kind of dissect the molecule out. And I want to just step back. We're seeing a lot of data getting presented, alpha emitters, beta emitters. So there's the target, And so the most robust data we've seen thus far has been obviously for PSMA as the target. It's an androgen-regulated gene. We've seen some early data on KLK2. There are other targets as well, STEAP1, STEAP2, DLL3, which is seen more in the neuroendocrine tumors. So there's, what are we going to block on the tumor? And there's heterogeneity around that. Then there's the carrier system that I talked about. It's just a small molecule. You've got peptides, you've got antibodies, and these all have slightly different behaviors within, an individual with regards to their toxicity profile and their distribution pattern within the body. Are they cleared in the reticular endothelial system? Are they cleared in the, kidneys? Then you've got your linker. You can have a chelator linker, with DOTA or DOTOGA or chemical linkers, and then you've got your types of radiation. You've got your beta emitters, lutetium. You've got your alpha emitters, actinium, radium being alpha emitters. So the same concept applies actually for antibody drug conjugates as well. You just change it from a radioactive isotope to a chemotherapy payload. And so I think this is sort of the mechanism, the composition of these agents. So we're going to start with radium. Going back into the old days, radium is a naked alpha particle. It's in the same column of the periodic table as calcium, is a calcium mimetic, and goes into areas of calcium turnover within the bone microenvironment and actually targets the bone microenvironment where the tumor sits, as opposed to directly targeting the tumor itself. It goes into sort of the area where the tumor is causing destruction in the bone. And the landmark study that led to the approval of radium-223, radium is the first radiopharmaceutical to demonstrate an improvement in overall survival for any malignancy. This trial was enrolled patients with MCRPC who had received docetaxel or declined docetaxel. They had to have symptomatic disease. They had to be on analgesics. They couldn't have had lymph node greater than 3 centimeters, visceral disease, cord compression, all that. This was a later line study. Patients were randomized 2-to-1 to radium versus placebo with a primary endpoint of overall survival. You all know the data. It demonstrated improvements in overall survival. Median OS in the radium arm was 14.9 months compared to 11.3 months with placebo, with a significant improvement in time to first symptomatic skeletal event with administration of radium. And then when we look at other key secondary endpoints of time to first symptomatic skeletal event, time to increase in ALK-Phos, we do see improvements there. We know that radium does not cause any change in PSA, I think largely because this drug targets the tumor microenvironment as opposed to the tumor itself. I think that's why we see the ALK-Phos declines with this agent. And so, it's been a long time since when radium-223 was approved, with lots of other treatments entering into the treatment landscape. We didn't really have robust utilization of the ARPs in the MCRPC at the time that radium-223 was approved. And so there's been a series of real-world evidence data that have tried to characterize the utilization of radium within the more modern landscape. I think when we look at modern-day real-world data, we're seeing an overall survival of around 15.6 months in patients who received radium. This is from the time of first onset. And then this was a study that actually looked at rates of toxicity with radium, and it's broken down in green here, people who had no prior chemotherapy, in blue, people who did have prior chemotherapy, looking at the effect of bone marrow suppression or need for a transfusion, in those various contexts, low use of ESAs with these agents, low use of growth factors with these agents. And then here was another real-world study with radium-223. This was a retrospective analysis looking at over 1,300 patients who were treated with radium. And you can see the different strategies for utilization, whether it was monotherapy, whether it was combination, meaning combination with an ARPI, with both agents started temporally at the same time as one another, or kind of this layering effect of starting one, then layering in the other. You can see the different breakdown of the different modes in which radium-223 was administered. In this data set, we see a little bit longer real-world overall survival of 22.9 months. And then you can look across the different lines of therapy, the proportion of patients that were able to actually complete 5 or more doses. So the earlier utilization, the more likely you're actually able to get through all 6 planned and intended doses of treatment. All right, I want to highlight the Piece 3 data, and we're going to see some upcoming data on PSA response from Piece 3 later on at the meeting. This was a trial that enrolled patients with mCRPC and bone metastases. They were asymptomatic or minimally symptomatic, kind of different than the Alsimca population. This was first-line mCRPC. These patients did not get escalated in the MHSPC setting when the trial was designed. That wasn't the standard of care. And so they were randomized 1-to-1 to receive the combination of radium-223 with enzalutamide versus enzalutamide monotherapy. And stratification factors based off of pain, prior DOSI use in the MHSPC setting, the use of bone-protecting agents, and in the context of the study, there was an early amendment mandating the utilization of bone-protecting agents to mitigate the fracture risk that these patients could be at risk for, and then prior abiraterone use, very limited prior abiraterone use in this context. The primary endpoint was rPFS. Here's the baseline characteristics that were pretty well balanced between the groups. The trial met its primary endpoint with a statistically significant improvement in rPFS with the combination compared to enzalutamide. We see a 19.4-month rPFS compared to 16.4 months. And then with regards to the overall survival, the data are still immature. You can see the curves crossing early on. But, pretty encouraging to see a median OS of 42.3 months in the frontline mCRPC setting, at this stage of the disease. So hopefully we'll get more a follow-up on OS in this context. When we look at the adverse events, I think, really pointing your attention to the grade 3-5 drug-related AEs, certainly a little bit more toxicity with the combination at 28%. Deaths due to AE very low in the context of this study. And then the AEs of special interest, hypertension, fatigue, fracture, anemia. We do see slightly increased rates of hypertension with the combination, very slight increased risk of, anemia and fracture that is seen as well. Okay, next we're going to go into lutetium PSMA 617. This is a beta-emitting radioligand that's conjugated to PSMA binding peptide. So this is a small molecule that targets PSMA on the cell surface and internalizes a beta emitter into the cell. There can be a bystander effect in the surrounding nearby cells. We know that PSMA is overexpressed in over 80% of mCRPC cases. It's kind of a misnomer because PSMA is expressed in other parts of the body, the salivary glands, the kidneys, the small bowel, where it can be expressed. The data that led to the approval of lutetium came from the VISION study. This was a late-line population, patients post an RP, post-taxane, and patients needed to have PSMA PET-positive disease as defined by that criteria here. We won't go through that. They weren't mandated to have a concurrent FDG PET. Patients were randomized to receive standard of care with lutetium, and that standard of care could have included an ARPI, could have included Decadron. It did not include chemo or other agents of that nature versus just standard of care. And this was a positive trial resulting in a statistically significant improvement in overall survival with a median of 15.3 months in the combination arm. And then here's the safety data. I think the big things we watch out for are the cytopenias with this agent, the fatigue, the dry mouth, which can occur, and sometimes some GI toxicity as well. And then the PSMA-4 trial actually looked at the utilization of lutetium in the pre-chemotherapy setting. This trial randomized patients 1-to-1 to receive lutetium alone, not in combination with an RP or standard of care versus an RP switch. In a PSMA selected population by gallium PET imaging. Crossover was allowed in the control arm over to the lutetium arm. We see a rPFS benefit of 11.6 months with lutetium compared to 5.6 months with the alternate RP. OS, trending towards a betterment with lutetium with a hazard ratio of 0.98. We do see dramatic PSA responses. You can see the waterfall plots up there with this agent. And because of this data, we saw recently the label expansion of lutetium into the pre-chemotherapy era and pre-chemotherapy setting for patients with mCRPC. In the interest of time, I'm going to kind of scan through ENZA-P. These were Australian-based studies that looked at the combination of enzalutamide versus enzalutamide and lutetium in a high-risk population. You can see the really high-risk factors that were kind of used to enroll patients in the context of this study. This was a positive trial for rPFS and also showing a strong signal or improvement in overall survival as well. And then the SPLASH study is a slightly different radiopharmaceutical. Actually, the key difference between this agent and that of lutetium is largely in the linker, but this was a little bit lower dosing than what was used in VISION and PSMA-4, 6.8 gigabecquerels given every 8 weeks for 4 cycles versus the alternate ARPI. This was a positive trial resulting in an improvement in rPFS. The rPFS here was seen at 9.5 months, compared to the 11 plus months for PSMA-4, and alternate ARPI kind of holding steady right at that 5 to 6 month range, with improvements in objective response rate. And we don't have an indication for that agent as of yet. The upfront PSMA study was a investigator-initiated trial that was recently presented at ESMO, actually looking at integrating 2 doses of lutetium in the MHSPC setting. The trial did meet its primary endpoint of undetectable PSA at 48 weeks. Very provocative data around what we could potentially be seeing with some of the studies integrating PSMA radioligands into the MHSPC setting. So we will skip through that. So in conclusion, we know that radium-223 is a life-prolonging therapy for patients with CRPC and should be considered. Lutetium PSMA is now available both pre and post chemotherapy for patients with PSMA-expressing disease, and lots of agents to look out for in the future. All right, that was a whirlwind. Okay. So, all right, Dr. Agarwal, you want to take us through your first case?
Yeah. So this is one of the cases seen by us, May 2021. This is a 73-year-old man. And just to take a step back, patient presented with high-volume metastatic HSPC in 2019 and was treated with ADT plus docetaxel chemotherapy. And after being on this treatment, upfront docetaxel and then continuing ADT, about 2 years after, patient develops mCRPC. So we can see the bone scan. It shows new bone metastasis. And now in May 2021, what should we do? So we had a trial available at that time, which was randomizing patients to enzalutamide versus enzalutamide plus radium. It was an IIT study. So we did do the trial. We did enroll the patient on the trial. The PSA was 30 to begin with. And patient, this is a genomic profiling of the patient, really did not have any targetable mutation at that time. And patient was started on enzalutamide plus radium in June 2021. Patient received 6 cycles of radium and then continued enzalutamide and had stable disease without any progression for the following 2 years. I'd just like to bring your attention to the fact that in this entire trial, small trial, 30 plus patients, we did not see any skeletal events. And one of the reasons was every single patient received a bone modifying agent throughout the trial. So with that, I'd like to give the mic to Dr. McKay.
All right. So who do you guys feel, or guys and gals, I should say, feel that we have the ideal candidate for radium in the modern era now? Obviously L-Simca was done more than a decade ago, but who are you giving radium-223 to currently? Dr. Beltran, you want to kick us off?
Sure, yeah. I think radium is sometimes forgotten now that we have other radioligands, but I think it's wonderful to have so many options for patients and to try to get everything into the patient at some point. And I'm a fan of radium, and I like the data of PIECE-3 to be able to, for patients that don't have an ARPI early on, to have that and don't have a BRCA mutation, to have that option. It's for bone-only mets, and so giving it early makes sense. And there is data on safety of sequencing with Pluvicto, and so the question is really where's the sweet spot for that? I can't say I have a specific sweet spot in my clinic. It kind of depends on going through all the options and the availability and a lot of other factors when making that decision.
Yeah. Dr. Armstrong, what do you think? Where do you place radium?
Yeah, it's a great question. I mean, I think the ERA 223 study taught us that too early, without bone protective agents, may harm patients because of insufficiency fractures. But as Neeraj mentioned, when you use denosumab or zoledronic acid, you really dramatically drop those skeletal events, and then you can actually see the benefits of radium, perhaps synergistically with an ARPI. But then with PSMA lutetium coming out, patients are flocking to that because there's a little more of a short-term benefit. You see the PSA go down, you see objective responses and actually remissions. You don't see that with radium. You see more of a delay in progression, symptomatic improvements, delay in spinal cord compression. So it's really important, but I think we need to do better. I think alpha particles could be added to PSMA targeting therapies. Alpha particles could be added to other cell surface antigens, and that's where I think you'll see some emerging data over time. But I do like radium. About half the patients in the U.S. sadly die of prostate cancer without ever getting docetaxel, and that's a choice. And radium is a great alternative to a taxane. It improves survival just as much as our best therapies.
Yeah. Andy, I'm so glad you brought that up. Universally, MCRPC is a grossly undertreated disease in the U.S. and I think globally. 25% of patients will never see any life-prolonging therapy for MCRPC. And of the people that receive first line, only 50% of those will ever receive second line. And it is just grossly undertreated. Utilization, docetaxel utilization 10 to 15% in the MCRPC setting. I mean, in the US, it's a little bit higher in Europe. So I think we owe a service to our patients. Like, there are so many life-prolonging therapies. There are targeted therapy options. There's radiopharmaceuticals. There's chemotherapy. There's bias as much in the physician in offering a therapy. So I think we need to be strategic about how we make sure we sequence every single life-prolonging therapy that a man can receive and wants to receive in their treatment. Dr. Saad, do you have anything to add?
Well, coming back to the question of timing, timing, and we've published, and several have published, the importance of at least 5 to 6 cycles. So you have to intervene when you've got this sweet spot of getting the 6 cycles. If you give too late and you get 2 or 3 cycles, it's the same as a placebo. You're not going to get, it's a cumulative effect of radiation. You need to get it in. So in our practice, most patients will discuss it after the ARPI. With the Piece 3, we're working on trying to get approval in combination. And the paper came out yesterday, so anybody wants to read the whole thing, it came out in Annals of Oncology yesterday. But I presented data that when you combine the bone protective agent with radium and enzalutamide, compared to getting patients without the bone protective agent, it was over 1 year improvement in rPFS and overall survival. It's hypothesis generating small groups, but those patients were followed so long we have mature data. So the importance of bone protective agent it seems to go beyond just preventing fractures.
Yeah. And you can see all the real world data that we shared, the MCRPC survival is on the order of around 20 to 24 months from the real world data. Now, I know we can't compare directly to the trials, but from the Piece 3 trial, the median OS was like over 40 months, like 42 months, close to 4 years almost. And so I think we need to think about that. Obviously there's some bias, but how we integrate the data. Yeah. All right, Dr. Saad, you want to take us through our next case?
Well, very short case, just to illustrate a patient who had radiation therapy for localized disease in 2018. He had recurrence, was metastatic hormone sensitive in 2021. And at that time, he was put on ADT and apalutamide. Unfortunately, he progressed after 2 years on apalutamide, went up to 5.7. And we're doing a randomized trial in Canada that's addressing one question that keeps coming up. What is the value of lutetium versus docetaxel in first-line MCRPC after ARPI? So really, patients who need to get docetaxel, so this is a randomized trial that's called Pluto. Hopefully we'll be able to present it at ESMO this year. So he was randomized to the lutetium arm. So it gave him the opportunity pre-chemotherapy. His PSA after 1 cycle had dropped from 5.7 to 3.7 and became undetectable after 4 cycles. and he remains totally undetectable. I saw him just a couple of weeks ago before coming here, and he's 0 ECOG. He's completely free of disease and no progression of disease. So this is, I think, not all patients respond like this. So why this patient responds so well, we need to work on how to predict who's going to get the best response. And the trial is going to be looking at DNA, circulating DNA pre-treatment. At progression, they switch to the other one. We're going to have more ctDNA. So hopefully we'll try to better predict who's going to be better served by lutetium or docetaxel.
Yeah. In your clinical practice, who do you prioritize for docetaxel versus lutetium? What are the factors that may sway you one way or another?
Well, the data is a little bit disappointing when you have liver metastases. We talked about the problems with liver metastases. And when we have doubts if patients are a good candidate, we'll do PSMA and FDG. And if there's a lot of discordance, I think the Australians have done a good job to tell us using double, we don't do it to everybody, but in patients who really are doubtful whether lutetium is the right choice, because cabazitaxel is a very good drug, after docetaxel, but for patients with liver metastases, we probably would favor chemotherapy.
Yeah, go ahead.
Just a plug this week for a very nice paper that came out from the therapy study looking at cell-free DNA predictors of who benefits from PSMA lutetium versus cabazitaxel. And I don't know if your patient, Fred, had molecular profiling, but in this study, there were 2 molecular signatures that were associated with better responses, ATM mutations and PTEN loss. That was a little surprise. But ATM is a radiosensitizer when it's lost and suggests that could be a potential predictor. It's not a great predictor of PARP sensitivity, so at least maybe we'll have something for these patients.
Yeah, they have all the testing, but all the ctDNA is still secret. Alex Wyatt is doing it in Vancouver, so we're blinded to all of that.
Okay.
Yeah, that's very exciting, I think, where ctDNA is going in prostate cancer. So for the interest of time, we are going to get to our final module, saving the best for last, Dr. Beltran, promising novel agents and strategies under investigation.
Thank you. So it's really exciting to see new drugs with new mechanisms of action reading out in phase 3 trials and showing promising results in early phase clinical trials leading to phase 3 trials. Today I'll highlight 3 different approaches across the disease continuum. The first is a CAN 2409. This is a locally delivered oncolytic therapy that is intended to vaccinate the injected tumor as well as elicit a systemic response. And this is being developed not only in prostate cancer, but in other cancers like pancreatic cancer and lung cancer. The drug consists of a non-replicating adenovirus engineered to deliver a gene-encoding herpes virus thymidine kinase. And when the patient takes oral valcyclovir, the antiviral, that thymidine kinase is converted to a phosphorylated nucleotide that goes into the tumor genome, resulting in cell death. Overall, this results in immunogenic cell death, release of tumor-specific antigens, as well as a systemic immune response. So we're going to be seeing, by the way, results of the phase 3 trial at Tuesday's oral abstract session. So I'll just give you some more on the mechanism here. So this drug here, this is a schematic from the company that just to highlight again where the tumor is, the drug is injected straight into the tumor. In this case, it'll be it's localized prostate cancer in the prostate. The patient takes oral valcyclovir. Again, there is a local cytolytic activity, and then there is a CD8-mediated T-cell response and systemic response, which theoretically could have impact on even the non-injected tumor sites, metastatic disease. So the phase 3 trial of CAN 2409 is for patients with newly diagnosed intermediate or high-risk localized prostate cancer that are intended to be treated with radiotherapy. This trial enrolled 745 patients, and it was stratified by risk group as well as ADT use. 2-to-1 randomization to CAN 2409 plus the prodrug valcyclovir plus radiation plus or minus ADT versus placebo valcyclovir with radiation plus or minus ADT. And the drug, again, is injected into the drug or the placebo is injected into the prostate, and there are 4 injections during the course of radiotherapy. And the primary endpoint is disease-free survival, which includes distant mets as well as local or regional failure. And there were repeat metastatic biopsies, repeat prostate biopsies as part of the study to confirm a local recurrence. The data that's public so far has suggested that it's well tolerated, chills, fevers, flu-like symptoms that are mild and reversible. And these are the data that's public so far. We'll be seeing updated results on Tuesday with a hazard ratio of 0.7 favoring the vaccine therapy with a median follow-up of 50 months. So interesting data and excited to learn more about this. The next approach that I'll talk about is in the de novo metastatic hormone-sensitive prostate cancer setting, the Capitello 281, which we don't have data yet, but should be coming soon. Just a background on this. This is the trial of capivasertib plus abiraterone ADT for patients with PTEN deficiency, MHSPC, de novo MHSPC. And so we know the PI3 kinase AKT pathway is dysregulated in prostate cancer and other cancer types. Prostate cancer is a very important oncogenic pathway, and it's primarily driven by PTEN loss, which is present in about 25% of patients with de novo metastatic HSPC. PTEN, in addition to PTEN loss, which is usually by genomic deletion, we can sometimes see AKT mutations, PIK3CA mutations, or PTEN mutations. So the whole overall pathway is dysregulated in quite a proportion of HSPC and even more in CRPC. And there's strong preclinical rationale that supports a crosstalk between the AR pathway and the PI3 AKT pathway, supporting a rationale for combination therapy of using an AKT inhibitor and an AR pathway inhibitor. And in CRPC, we did see data in the Hepatessential 150 trial of hepatosertib plus abiraterone in CRPC. This was for all comers, and there was a seemed to be a better RPFS benefit in the PTEN loss patients, and they measured this by IHC showing loss of 50%. There were some interesting correlations with genomics as well, and there wasn't a benefit in the intention to treat, and there wasn't an overall survival benefit, but this really, I think, provided strong, biomarker insights into the HSPC trial, which is the Capitello 281 trial, which is taking patients with metastatic HSPC, stratified by volume of disease, and randomizing them to capivasertib, abiraterone ADT, or placebo with an RPFS endpoint. And the cutoff for this, so in this trial, everybody, rather than all comers, everybody has to have PTEN loss, and this is defined by IHC, and this time using a cutoff of 90%, meaning the tumor has to have less than 10% positivity based on this specific assay, the Ventana assay, which was also used in the CRPC studies. And this was based on analysis of the Hepatessential trial showing that those patients with greater than 90% loss had an improved RPFS versus those that were lower. And so we did hear a positive press release in November, and looking forward to seeing the data for this study. And then the final strategy that I'll touch upon is in CRPC, where we have data, early phase data, that is supporting phase 3 development of mevrometostat in combination with enzalutamide in CRPC. So targeting the epigenome, I think, is a really exciting area, and many cancers, including prostate cancer. EZH2 which mevrometostat is an EZH2 inhibitor. EZH2 is part of the PRC2 complex, the polycomb repressive 2 complex, that acts as an epigenetic modifier, depositing H3K27 trimethylation to the gene, to gene promoters to repress downstream gene expression. And in normal development, EZH2 and the PRC2 complex are really important for lineage specification. And in prostate cancer have been implicated in lineage plasticity, including the transition of adenocarcinoma to a neuroendocrine phenotype. If you look at EZH2 expression, there's higher and higher levels of EZH2 expression in later stages of the disease, in CRPC, and in those that develop neuroendocrine features, with downregulation of EZH2 repressed target genes. There's also a non-canonical role of EZH2. Instead of being a repressor, it can also be an activator, interacting with androgen receptor to drive AR signaling, interacting with other transcription factors to modulate gene programs. So there's strong rationale for also combining EZH2 inhibitors with AR pathway inhibitors. So the mevrometostat, the EZH2 inhibitor plus enzalutamide, has been studied in an early phase trial with an open-label dose expansion study in the post-abiraterone disease setting. This is a MCRPC stratified by prior chemotherapy, Patients who were randomized 1-to-1 to mevrometostat plus enzalutamide versus enzalutamide alone with an RPFS benefit, RPFS endpoint, with, I would say, a very striking RPFS benefit with a hazard ratio of 0.51. So early data, but pretty striking with the combination. Radiographic responses were seen as well, higher in the combination arm with, I think it's like 20, can you read that? Sorry. 25%, sorry, I can't read, versus enzalutamide alone. And as far as toxicity, asthenia and GI symptoms tended to be the most common side effects. So there was a number of outcomes from that trial looking at PK and PD markers, and ultimately, which was presented at GU ASCO this year, and ultimately a dose of 875 milligrams of food was the recommended phase 3 dose based on these early phase trials, and we're looking forward to 2 phase 3 trials. One is the MEVPRO-1 study, which is looking at mevrometostat enzalutamide versus physician choice, which is docetaxel or enzalutamide in patients with mCRPC previously treated with abiraterone. And then another trial, the MEVRO-2 phase 3 trial, MEVPRO-2, comparing mevrometostat plus enzalutamide versus placebo plus enzalutamide in ARPI naive patients with mCRPC. So exciting to see these promising new targets and therapeutic approaches. I'm looking forward to seeing more in this meeting and meetings to come. Thanks.
All right, fantastic. Well, wonderful job, Dr. Beltran, taking us through all that great data. I didn't even know about that vaccine. I'm like really curious to know what that's all about. So, all right, Dr. Armstrong, do you want to take us through our next case?
Another real-world case. This is a gentleman who presented with back pain to the emergency room after having a negative sports medicine physical. It was getting a bit worse with activity, still bothering him at night. His PSA was found first ever to be 71. His alk phos was high. This is literally a case from not too long ago in my practice. So it was newly elevated. The alk phos was checked last year, never had PSA screening. His PSMA PET had, borderline high volume, 4 bone mets, PSMA avid disease, but technically low volume. Certainly by conventional imaging, it'd be low volume. He had a prostate biopsy that showed very high-grade disease, and he was found to have P10 loss, surprise. He had a TMPRSS2 ERG fusion, no BRCA alterations or HRD, is PD-L1 negative, and he starts on ADT-ABI, and he inquires if there's any other approaches that could improve his overall survival. He's otherwise healthy, married 45 years, and no diabetes or other medical problems. So, I guess thinking about the Capitello data and the press release, we don't have any data on overall survival, but, what do you think about progression-free survival? Is that enough justification for you to use this agent, or would you like to see overall survival?
I think the bar is high for MHSPC. I know for me personally, I think we want to be showing that we're demonstrating that we can make people live longer. I think we've set a really high bar in that context. I think.
So why is breast cancer different? And they have all these approved drugs for progression-free survival.
Yeah, go ahead.
I think it's a balance of toxicity and safety and efficacy. So I am willing to not have the overall survival data if the combination is very well tolerated and delay RPFS. I personally think delaying castration resistance, which is a symptomatic lethal form of disease, is meaningful to our patients. So if I see RPFS data and drug is pretty well tolerated, I'll use it.
I think, too, the other thing to think about is how the trial was designed. So when we say there's no OS, if the trial wasn't powered to demonstrate an OS and you're just seeing a signal and that's how the trial was designed, it was not powered on OS, then I think that needs to be taken into consideration, because otherwise trials get much larger, longer to complete when we do have that high bar.
Neeraj, you mentioned you use genetics to decide in low-volume patients who to give triplet therapy to. Would P10 loss push you to give triplet to this guy?
Again, it will depend upon the data. Yeah. I would like to see the data, see how hopefully they will provide us the cutoff for different level of P10 loss. Mm-hmm. So ultimately, we'll all have to delve deeper into the data and see how we can apply that to our practice.
Mm-hmm. Yeah. But for now, we don't have that possibility. Yeah. But for docetaxel, this patient presented with high alk phos and pain pain is a prognostic factor for early death in MHSBC. So even though he's low volume and he's got Gleason 9-10 disease, I am concerned. I would discuss it and have him make that decision, and I would treat his prostate.
Yeah.
I mean, he's got very bad disease in the prostate, so he's borderline high volume. I think treating the prostate, the question is the docetaxel, and that's a patient decision choice. He looks like he's going to live long enough to need it. So if he's going to use it in a year or two, I'd rather give it to him now than wait for him to be castrate-resistant post-ARPI and have a lot less response with docetaxel. So it's a shared decision.
Yeah.
I agree.
I think, too, when we think about the biomarker, we're largely doing molecular profiling for these patients. That's how we're detecting that they have PTEN loss. I don't think I've ever checked PTEN IHC in my clinic on anybody with advanced disease, and the integral biomarker in the context of the Capitello study was a very practical IHC assay. Andy, I know that you are the biomarker king. Any thoughts about that?
Well, I don't measure it either, but so you have to have a qualified analytically valid assay, and that's the whole point of the Capitello study. I still have issues with the Capitello study. We had that open at our site, but it does not allow docetaxel. You can have a high volume patient and you can't give docetaxel if you're on the Capitello study. So it's not really testing a triplet versus a triplet. It's kind of lowering the bar, which I think we need to raise the bar for everybody instead of lowering the bar in these trials.
Thank you for that. All right, we'll get to the last case. I know we tackled these questions during our back and forth when the case was up. So this is the final case of the evening. 65-year-old gentleman diagnosed with de novo metastatic disease in 2022, PSA 125, Gleason 9, multiple bone mets on imaging, on bone scan, no visceral mets. He's a clinical T3B-N1, M1B. Has genomic profiling on his prostate biopsy. He's found to have a TP53 mutation, no HRR alterations. He gets started with ADT abiraterone and has an initial decline down to 0.2 within 3 months, does well, but eventually progresses to MCRPC with a rising PSA and bone scans showing some new bone lesions, no visceral metastases. And, he's not had prior enzalutamide exposure, not had prior chemotherapy exposure. And just to kind of go through his labs here, his PSA now is 7.2, his ECOG is 1, intermittent kind of bony pain, hemoglobin 13.1, good white count, good platelet count, good bone marrow function. He does have more disease than meets the eye on his PSMA PET scan, no liver mets, and doesn't have measurable disease. And he is actually a perfect candidate for the MEVRO-1 study and actually enrolls on that trial. So as we think about mevrometostat, where do you see this agent eventually being placed in the clinic in the context of other treatments with regards to lutetium, with regards to docetaxel? This patient was docetaxel naive. He was also not exposed to, a radioligand therapy. Maybe Dr. Saad, you can help us out with this one.
I think, like everybody else, I'd like to see the data mature and all the rest, but obviously it's going to be a very attractive alternative to what we have, sticking to, because going just from AbbVie to Enza, I know it's done a lot. We don't do that in Canada. We don't have the right to do that. It won't be reimbursed because the data is not strong enough. So I think we need to do more than just switching ARPIs. I think that's not the right thing to do for the majority of patients. So this becomes an alternative. Outside of this, I think he's an ideal patient for either radium or lutetium. I think they're both, especially this guy has nothing, and even on PSMA PET doesn't have much in terms of lymph nodes. So, The question is radium first or lutetium second, and your point is well taken. This guy should get multiple lines of therapy, including both.
Dr. Agarwal.
So the good thing about this trial, docetaxel is a competitor. So we will know if docetaxel, which is a very valid choice in this patient, should be applied or the combination. And we'll get the answer hopefully in the near future.
All right. Well, maybe we'll spend the last 3 minutes round robin. What's your the agent that you're most excited about in prostate cancer that's in development? Maybe we start with Dr. Beltran and work our way down. So,
I'm really excited about the whole radioligand space, and you mentioned some of the exciting ones that we already have data for, but there's lots more in the pipeline, including the actinium drug, PSMA drugs, and then other cell surface targets, whether it be also ADCs, just start targeting the surfaceome. I think is it something that we're going to see more and more
I love that surfaceome. That's a new word. I love that. Okay, cool. I'm going to use that. Okay, Dr. Agarwal.
I think it's going to be the combination therapies. So hopefully many of these therapies will show benefit, and next step will be to combine. I feel excited about beyond RLTs, antibody drug conjugates, T-cell engagers, these signaling inhibitors, and I think this is the best time to be a prostate cancer oncologist.
Awesome. Dr. Armstrong.
I'm going to be a little more boring, but I do love targeting the surfaceome. So xaluritamig, STEAP2, the KLKs, the HK2s, the radioligands, they're going to be incremental. We're going to see PFSs of maybe a year. Yeah. But that's not, we need to do better than that. So I would like to see combinations targeting multiple surfaceomes. But I think the biggest impact will be kind of when Fred gave his opening lecture, moving the ARPIs into a curative intent setting. So we put ourselves out of business, preventing CRPC entirely.
Adapt.
Yeah.
Could be adapt, could be
Yeah.
the earlier trials like Stampede taught us, but Enza-Rad, Dazzle HiCap, Atlas make a big difference for a larger public health section.
Absolutely. And so it's
Fred, take us home.
It's hard to add to all this, but I think my dream is that we tackle this disease with quintuple therapy if needed. We really need to hit extremely hard and then back off. I would really like us to stop castrating men for the rest of their life because they've got advanced lethal disease. Hit them hard, pull back, but know what biology needs to combine. We need to go the lymphoma route, the leukemia route, and do a better job of not just making this a chronic disease.
Thank you so much. Oh my God, give our panelists a round of applause. They did an amazing job. Fantastic cases, really tremendous work, everyone. So thank you, everyone.